So go ahead and just do me a favor, doctor, and say your name for me and spell it for the record.
Sure. My name is Jacob Glanville, JACOB GLANVILLE.
Okay. Yeah, so what is your analysis when you look at our charts and the number of cases we have here now and what we could have in April as well as May?
So what San Diego is experiencing now is pretty typical of what we are seeing in many other locations in the United States and indeed around the world. This is the acceleration of cases that's just typical of an outbreak. It's somewhat alarming, and the reason countermeasures are being enacted is that, as you can see from projections made by Live Well San Diego, we are in a position where pretty quickly we're going to run out of ICU space at hospitals. And that is really the triggering concern that has given rise to shelter-in-place ordinances in California and quarantine efforts and social distancing efforts throughout the world. Those projections, you are largely on a sort of a course where it's unavoidable over the next 2 weeks after the projection. That's because the people who are about to get sick are already out there getting other people sick and getting sick themselves. But measures, once you enact them, they do start taking an effect within about, say, 2 weeks out. So it's not unavoidable to run into these sort of catastrophic issues with hospital space. That said, at this point, San Diego, like many other locations around the country, should start preparing to enable overflow capacity in gymnasiums or other locations to be able to handle large numbers of patients all arriving at the ICU and simultaneously.
So do you think that mid-April is going to be the worst we're going to see? Do you think it's going to be mid-May that's going to peak, or where are we looking at a peak happening?
So most of the projections we've been seeing are a mid-April peak. The shelter-in-place measures, to the extent that they're being adhered to in San Diego, will slow that peak down, will flatten it, and that could push you out into later April. But that is the peak that's being anticipated. And the good news here is that telling everyone to go home is not great for the economy, but it definitely helps reduce the outbreak, because people are either in their homes and there's no one in their home that's sick, so you're just waiting, and you're less likely to get sick, or there's someone in your home that's sick, in which case you may get the other people in that home sick, but at that point everyone's going to develop immunity and get better. And so when people reemerge from a shelter-in-place ordinance, there are less active cases in the community, so it sort of dials down or partially resets the clock. Unfortunately, it doesn't seem like it's good enough to get rid of all active infections. So when you let everyone come back to work, the risk is that the outbreak resumes, but it does buy us a period of time.
Some of our viewers have been wondering, I mean, the first reported case in San Diego wasn't until March 9th, the first confirmed case, I should say. Do you believe, though, that we had coronavirus here in San Diego months before March?
Yeah, so it's almost certainly the case that California, as well as many other states, had active cases that were unmonitored even back since January. So when you see the alarming rapid appearance of multiple cases, that's more a factor of more tests being conducted rather than a huge outbreak suddenly appearing out of nowhere. Those people were already in our communities. They were already being sick. Some of them were already going to the ICU. They just were being misdiagnosed as influenza or some other serious disease. Where now at least the monitoring's in place, and we're starting to get a handle on the rate of the outbreak. That's going to appear alarming by the numbers because there's two things going on. One is there is an actual outbreak taking place where more people are getting infected. But the second is that we're finally getting a handle on how many people are actually infected because we're starting to do testing. The good news here is that consistently testing large numbers of individuals is one of the first and important steps on containing and mitigating the outbreak.
So based on the last time we spoke, which is a couple of weeks ago, are you more optimistic now than you were 2 weeks ago about the number of cases that are going to end up in California and in the United States? Or are you feeling like this is, on the same trajectory that I predicted a couple of weeks ago?
So the big thing that's happened since the last time we talked was the statewide shelter in place, and that is absolutely the move in the right direction, and that's resulting in a better outcome for California than we were projecting until it was enacted. That said, we're still running into the problem in California where we're going to run into significant issues with hospital capacity. There are other areas in the country that have not enacted such strict measures, and those areas are going to suffer. I'm particularly concerned about New York that has enacted very strict measures at this point, but they are the absolute epicenter of the outbreak here in the United States. But if you look at a map, there's a large troubling problem that the majority of the United States is now undergoing outbreaks, and many of these regions are not enacting the kinds of social policies that would be necessary to stop the outbreak. We have surpassed China by quite a bit at this point, and we are in a troubling period where the growth is not being mitigated in many areas of the country. So what I am anticipating is a very rough April in many areas of the country. The good news is California, because of the strong actions by the governor and by county leadership, is helping us avoid some of the worst aspects of the outbreak.
Do you think we need to do a nationwide shutdown for 2 weeks?
Ideally, it would be regional. So you evaluate where the outbreaks are. That requires that you understand where the outbreaks are, which requires that you do testing. So we need more testing. Then the shelter-at-home ordinances, they should be applied in areas where there's a significant outbreak that's going to, you can predict that you're going to run out of hospital beds a month later, and you can start making countermeasures. Everyone wants to avoid the Italy or the Iran scenario. I think it's not necessary you do it fully nationally, but there are regions where it needs to be conducted. I think the things that should be done nationally are a series of measures to support research and also support social policies, research into new medicines, and then social policies and financial support into enabling businesses where people don't actually need to be at work to be able to work remotely, and to shut down certain types of venues like large conferences and festivals and parties where that might be a hotbed for outbreaks.
Circling back to those charts for just a second, do you have a prediction of numbers that we'll see in San Diego based on the data that you see in front of you in April and in May? I mean, what do you think? Do you think we're being too optimistic with the projections we're putting out there? Do you think we're being too pessimistic? Do you have any idea on that?
These projections look reasonable to me. So my estimates from a month ago is I figured we would have about 50,000 cases in California by mid-April, and we still look like we're on track for something to that extent. We might do a little better than I was expecting because of the shelter in place, and that is a good thing. But I would operate with these assumptions that these are reasonable estimates at this point for San Diego. So San Diego should brace, like every other area in the country should brace, to make sure that the hospitals are not going to become overwhelmed. That is the biggest area that that this can cause trouble to society, is at the hospitals. And the good news is that's something that can be predicted and acted upon. So more hospital beds can be created. You can set up temporary ICU space. This was done in 1918 in the Spanish flu outbreak, and the same sort of thing we're starting to see happen throughout the United States. And you really, the reason that's important is you need people not dying in the waiting room. They're all going to show up at once. It's going to be rough. Even when you put these policies in place, there's going to be a peak, and you're going to have your hospital workers overworked, and you're just not going to have enough ventilators and oxygen tanks and other services that these people require. The second area that's just harder to protect yourself against is you can get a gymnasium, but how are you going to triple your capacity for doctors and nurses? If anything, you're actually having less doctors and nurses than normal because they are on the front lines of this thing, and they're much more likely to get sick. And so you end up having a problem of way more patients showing up and suddenly half as many medical staff because they get sick, they can't work, and indeed you want them isolated because you don't want a medical staff who's sick transmitting the disease to patients. So that's just a challenge we need to be ready for. I think there has been discussion around the National Guard and other federal resources that could be applied to help out regional outbreaks, such as what's going on in New York.
Switching gears just for a moment, the malaria drug trials. I know those have been happening here in the United States. We interviewed a woman last week who was part of the trial. She was at a VA hospital. I think she recently ended up leaving her home because she had finished her 14-day quarantine and essentially is better. What are your thoughts about what you've seen so far with that research, and do you think the malaria drug is effective at this point?
There's some preliminary papers have come out. They've showed mixed results so far. I'm still waiting on the complete studies to emerge. At this point, I would still recommend we'd be adhering to the treatment protocols from China and South Korea because they both have successfully reduced the mortality rate and the number of active cases. Now, some of that is unrelated to the medical process, but at this point, I think chloroquine should be included on the treatment protocol until we get evidence of whether it's effective or not. that is not to say it's that effective. At this point, you're basically just throwing all the spaghetti against the wall and seeing what sticks. In terms of remdesivir and Kaletra, it's similar. You hear reports in the media where people talk about like 1 or 2 patients who took the drug and then recovered. And I really wish they would not report like that, because randomly people go in and they get treated and then they recover, whether or not they receive that medicine. So it doesn't actually tell you anything whether that medicine's effective. So I worry that those sometimes serve more to affect stocks rather than actually tell us how to treat patients and help people. So I would just wait for the big studies to come out, and that's going to give us guidance. I would say none of those medicines are a great cure, because otherwise there are countries that are applying them that if they were really that great of a cure, like if they were as good as antibiotics, we would just basically not have that problem anymore in those countries, and that's not where we're at. So if they help a bit, and I think we're still waiting to understand how much.
Right.
Any new predictions on when you think we can return to life as normal? Do you believe it's still going to be the fall? And that's, optimistic in hoping that you guys are coming up with the drug to treat COVID-19.
Yeah, that's right. So the current projections are that we're going to have various paced outbreaks throughout the world. Places like California that can issue a shelter in place can do it for a while, and as China has. But as China is doing, at a certain point, you have to let people go back to work. And unless you've managed to entirely stamp out the outbreak, there's going to be some active cases, and they're just going to sort of reignite the fuse, and you're going to start having another outbreak. So there are ways to mitigate that. You have, after shelter in place, you could start doing much more aggressive contact tracing and testing to try to slow the spread. And people are adapting to the new normal of washing their hands more often and avoiding big parties. So all of these things help. But ultimately, this thing is so infectious, it's likely just going to continue to spread in human populations until we have a decent medicine. So my group is working on a monoclonal antibody therapeutic. We are happy to announce that we have completed the engineering, and we have some very potent antibodies that can be effective against the virus. We are sending them out to the military for confirmation testing and to Charles River Labs for safety and tox characterization. We've partnered with 2 different companies that are going to help us scale up large batches of the antibodies for production, and we're in discussions to set up human phase trials, phase 1/2 trial that would happen towards the end of the summer. That, pending good results that we see that the drug is safe and is helpful, mean we could start releasing it for compassionate use in September. That still is many months away, but by our estimation, that's the fastest way we can have a potent drug that could be curative and work efficiently on a patient in a hospital. And until that time, it's wash your hands, avoid unnecessary human contact, and wait.
So I probably buried the lead then on this whole thing, because that means you have come up with the antibody that can fight COVID-19?
Yeah, that's right. So we took a series of 5 antibodies from around 2002 that were able to neutralize SARS. So if SARS ever came back, these would be great antibodies against SARS. And the cool thing about the evolution of these viruses is that SARS and the COVID-19 causing CoV-2 virus, they're cousins. They're different, but not by so much. And so we are able to use a technology in our laboratory to evolve those antibodies against SARS to adapt them to now recognize the new COVID-19. And that data actually came in over this weekend, that we have extremely potent binders that are able to neutralize the virus's ability to engage with the surface receptors on cells that make it infectious. So it basically neutralizes the virus so it's no longer infectious. And we tried with 5 different antibodies because we weren't sure which one would work the best. All 5 worked. So we have a pretty powerful tool chest available to us right now to produce a final therapeutic. So now it's just going through these hoops of how quickly we can get the material ready, it validated, and go into the phase trials.
So would the drug be like a shot? Is it like a pill, do you think? Or are we too far away from even knowing? Or
Yeah, so it's a shot. We think we're going to be able to deliver it as a shot. So antibodies you have to inject. If they're weak, you give them as an IV bag, or you need a lot of them, and so the person has to hang out and get an IV. We've been deliberately trying to engineer extremely potent antibodies, because if they're potent, you need less material, and then you can just give it as an injection. That is called subcutaneous injection. That's really what you want, because you want to be able to go and give this to a bunch of patients at lots of hospitals, and you also want to be able to give it to hospital staff. So an antibody, you get 1 injection, and you have about 8 to 10 weeks of protection afterwards. And so that's a pretty powerful thing we could give to nurses and doctors and intensivists so that they can work in those spaces without risk of themselves getting sick. That's really one of the heroic but frustrating things about what's happening right now, is that medical staff are particularly susceptible to getting infected by COVID-19 because they're surrounding themselves with people who are very sick, and they seem to have worse cases on average than average community members, which we're not sure why that is. Is it because the sick people might be just venting a lot of virus on them at once? Is it because they're exhausted? But for whatever the reason, we need medical interventions to protect our medical staff because for their own safety and recognition of their work, but also just the practical thing. If half of your staff isn't working at the hospital, you've just halved your capacity of medical care. At the same time, you've suddenly doubled the need.
So just so I understand correctly, we're not talking about a vaccine against this. We're talking about if I got sick, I went to the hospital, this shot, I could get a shot in my arm that would cure me. Is that what we're talking about?
Yeah, that's right. So a vaccine, they give you a shot, and what they do is they give you little parts of the virus, and then your body, your immune system, spends like 6 or 8 weeks slowly building up antibodies in response to those little pieces of the virus. Because it takes so long, you can't give a vaccine to someone who's in a hospital sick, because by the time the vaccine would do them any good, they're already recovered or they've died. So and then the other problem with the vaccine is that the vaccine relies on your immune system to do its job, but the elderly or people that are immunocompromised, they don't respond as well to vaccines. And unfortunately, those people are particularly at risk of the COVID-19 disease. So an antibody, like what I'm making, skips the middleman. So instead of giving them pieces of the virus and it's the person's job to make the antibodies, we just give them the antibodies directly. So we have a syringe, you inject it into the person. Within 20 minutes, their body is full of protective antibodies that will neutralize the virus, and they float around in their bloodstream for about 8 weeks. So you can kind of think of it like an antibiotic or an antiviral.
Oh, okay. So do you take it before you get sick or as you're sick?
You can do either one. So for hospital staff, you'd give it to them before they get sick. And that would protect them so that they could now work safely in the hospital without risk of being exposed to the virus and then them getting sick. If you are already sick, you give the shot, and then they already have virus in their body, but as soon as you give that shot, then those antibodies are going to they go up and they bind all around the virus, and they basically block it so the virus can no longer infect any new cells. And so that immediately starts helping the patient get better. So it's useful in both scenarios. It's also part of the advantage of an antibody as opposed to a vaccine is that antibodies can be tested very quickly. With a vaccine, you have to give it to a whole bunch of healthy people. You have to wait for 8 weeks for it to take its effect, and then you have to monitor those people for months to see are they getting less likely to get infected than people who didn't receive the vaccine. So you have to take very large numbers of people, and you have to run very long studies. Whereas with an antibody, just like an antibiotic or an antiviral, you go take people who are sick, you give the shot to them, and you know within 5 to 10 days whether it was effective in protecting life. So they're much faster studies.
Will you be doing the trials then on patients here in the United States that are already sick? Is that what we can expect this summer?
Yeah, so this is a conversation we're having with the US government on exactly where that study is being done. We're also talking to the European Commission, and we're talking to interests in Asia, because we certainly want an FDA-approved phase 1/2 study done in the United States, but we want to make sure that when we're ready to release this, that we're able to release it to the entire world. So we're also having conversations to make sure we may need to run a parallel study in Japan, for instance, or in the European Union. It depends really on whether those groups view our study as sufficiently good that they would receive the medicine for compassionate use, or whether they want a parallel study conducted in their populations. So those are all conversations that are happening right now, and our goal would be to run all of those studies in parallel at the end of summer.
How excited were you when you guys realized all this hard work, all this 24-hour-a-day work you guys have been putting in really paid off?
I'll send you some photos.
Yeah, I can't even imagine. I mean, so hopefully you basically came up with a cure for COVID-19.
I have a remarkable team, and I think they just really kind of blows me away, the endless amount of time that they were willing to invest in this. We got a shelter-in-place order. The chief of police was on TV telling people to go home, and yet we got an exception to work just on this project, and they all volunteered. And I told them, look, if you guys can go home on a volunteer basis, we could work on this one thing. And I went home that night feeling defeated, and I woke up to an army, because my team was like, no, Jake, we're going to work on this. And they came in on shifts. They came in, braved the outbreak. They came in on nights and weekends to work on this. So it was immensely rewarding, but also I'm just deeply appreciative of their expertise, and they're willing to commit to try to help people here.
Well, I want you to know that I'm sure everybody in the world is just so grateful, for you and your team. If it turns out that this truly is the drug that we've all been waiting for and hoping for, that you guys put in all this hard work. I mean, thank you so much for all of that.
Yeah, sure. And there's more steps. We need to get that safety in place. We need to scale it up, and we need the phase 1/2. And that's ultimately the most important thing, that the drug doesn't hurt people. And antibodies are very safe because they're human antibodies. So when you inject them into a person, your own body just kind of thinks you made them, so it ignores them in most cases, but you still check. And the second is it needs to make sure that it's effective. We have strong reasons to believe these antibodies will be effective. We already know that these antibodies would neutralize SARS, and they would have been great drugs against SARS. Antibodies as therapies were what was ultimately the breakthrough cure for Ebola. We use antibodies as therapies for RSV in children to protect them from dying at hospitals, and they've been tested out by the Gates Foundation for HIV. They've been tested in influenza. So these are great molecules that are known to be effective on treating viruses. We know that these already are effective in treating the cousin virus. We just need to now prove that it's effective on treating this virus here.
And are you the only company in the whole world that's been able to come up with this?
So there are two other companies that are, I think, quite good, and they're working on antibodies as well. And there's a series of others that are doing development work on antibodies. So there's multiple groups working on antibodies because they fit this middle ground between the vaccines that take a really long time and the small molecules, small molecules that we're concerned may not be effective. And so there are groups working on it, but most people started from scratch, which is extremely time consuming to produce the antibodies. Our unique thing was where I was like, let's just skip a whole bunch of work and go find these antibodies that people spent 2 years already working on against SARS, and we can use our technology advantages that we can modify those to then take out this new virus. And then we're still testing this week, but because they hit the old SARS and neutralized it, and we've adjusted them to hit the new coronavirus, we think they probably are still hit both, and they may hit all the viruses in between, which is really exciting because this is a medicine that doesn't just treat coronavirus, the novel coronavirus, but it treats the old SARS, and it might treat many other viruses in between, which is ultimately what we need. Going towards the future, obviously we want to fix this current outbreak, but we shouldn't be myopic. We should look to the future and say, how do we as humans protect ourselves from these sorts of outbreaks in the future? And the solution are broad spectrum therapies that hit conserved sites on many different versions of the viruses. So the next time there's an outbreak, we have a medicine waiting.
Yeah. Do you, and just so I'm exactly clear, at what time and what day did you get the data that you were like, oh my God, we did it?
Yesterday at about 11 a.m.
Wow. Did you celebrate it all yesterday?
Yeah, we're a bunch of there till about 2 a.m. at the laboratory. So the data, that's when we first saw it coming in, and it came in throughout the day, coming off the instruments. I had told people the week of April 13th to buy us some additional time because sometimes, experiments, you have to repeat them, and sometimes you need more information. But, I build multiple bridges across every river to make sure I can achieve success. So that's why I engineered 5 different antibodies. And as long as one of them made it over, we would have been okay. In this case, we got a little lucky. We exceeded my expectations, and all 5 were successful. So we're in a pretty powerful position now moving forward.
Awesome. And what's the next time frame in terms of, do you already have the government approval? Like, are you guys going to be able to start the trials, for sure, starting in this summer? Or?
No, we're putting together. The things that are locked down are relationships with Charles River Labs to conduct the safety and tox studies. We have a partnership with 2 different groups to scale up the medicine. But the government, so far, they've agreed to do it, and they have the technologies, but we need to give them money to be able to pay for not just producing enough batch for one trial, which is already expensive, but they need to, in anticipation of success, be able to scale up to produce hundreds of thousands of batches. Because what we don't want to be is stuck like what happened with Ebola, where medicine worked and we showed how it worked, but then the people had to take a 4-month delay to produce bigger batches. We want to be in a position where as long as that data looks good, then we can start handing out the drug immediately. And then the other part is phase 1/2 trials are expensive. So I'm having a meeting this week with the military and the government to discuss it. I think the government should pay for this. They're putting together these very large bailout packages. Those packages serve to correct the economy, and there's no better way to correct the economy and save lives than to create a medicine so people can start going back to work. But I have not yet gotten them to sign off and hand the check over. So that's part of the politicking. I've been communicating with them since January, but now we're in a much more powerful position because we have the molecule in hand ready to go. So you can expect updates on that pretty quickly. So our technology, what we do is we take these old antibodies, and we have this, I'm a computational immunoengineer, so I have ways of using math and computers to engineer hundreds of millions of DNA variants around the starting antibody to explore mutants that could adapt to recognize the new coronavirus. So then we produced all of them, and for a while you're working on this stuff, but you don't have the answer, so it's kind of like a ship, that would it could try to run all its calculations on where land would be and look to the stars, but eventually you just have to place your faith in the math and then go into the darkness, and then hopefully you find the other shore. And so we were going through that process of panning and preparing the plates and the PPE. They're basically doing a bunch of scientific stuff to go find a bunch of the molecules. And eventually what we did is we took about 2,000 molecules that came out of these 5 different arms of discovery. And the eureka moment is you prepare those antibodies from the 2,000 molecules, and then you start exposing them to part of the virus that we'd also engineered, the kind of the Achilles heel. It's called the receptor binding domain. And if what we had done worked, then suddenly these things wouldn't just go bind SARS, they would suddenly start also binding to the COVID-19 virus. And then we saw that very vigorously. And there's basically these big instruments that give this readout, and you see this big blip when they go and they strike the other virus. And so that was what we saw coming in yesterday. I always call it a potential cure because we still need to see how it works in the human phase trial.
Okay. Is there anything else you want to say or add that I'm not asking you?
No, those are the main things. I would say, like, just the timelines. I've seen some people report like, oh, we made a vaccine in 2 days. You know, I mean, these are non-credible timelines. So I just want to be clear, like, we've created high affinity, they've successfully created high affinity neutralizing antibodies against COVID-19. They're getting ready to run safety studies and then go into phase trials over the summer. And our intention is to release it through compassionate use in September.
Do you consider this a vaccine?
It's an antibody. It's a treatment. It's an antibody treatment. Yeah.
So it's not a vaccine.
No.
It's not a vaccine. It's much faster than a vaccine.
Do we call it a drug?
Yeah, it's a drug. Yeah, it's a drug.
Yeah. Okay. Just make sure. Okay. Anything else?
An antibody medicine or an antibody drug. That's what they call it.
Okay. Great. Well, congratulations to you, and thank you so much for chatting with us. I really appreciate it.
All right. Sounds good. Take care.
Thank you. See you later.
Bye. Bye.